So we're going to blow through men's syndromes. It's not the most exciting talk, to be honest, but it's like, you know, it's very, very abscite heavy. You know that when men's syndrome is being talked about, the abscite must be close. So you just have to know these. I mean, how often are you going to see them in your career? Probably once, never, maybe. But they are tested heavily. So we have to know all the details. All right, Jamie, tell me what tumors come with Men1. Start easy.
Thyroid, hyperplasia, this one is like multilocular.
Okay.
Hyperplasia, and then you're gonna have pituitary lesions, with a lot of times they're gonna be like peanuts, gastronomas.
Yeah.
Oh, sorry. So I was like looking at the pancreas.
Right, tumor is wrong organ.
Pancreas, peanuts, and then pituitary.
Okay, yeah. So pituitary, parathyroid, pancreas, right? 3 Ps, Men1, 3 Ps. Just memorize that. All right. Men2A tests. Give it away. Okay, and which one is the most common? Yeah, so anytime you're talking about Men2, it's really a familial medullary thyroid cancer syndrome, and then you have these other things added in. And then 2B, what changes? Tests? Finish it out. Yeah, so other weird stuff, and then you still have the medullary and the theo. You drop the parathyroids. All right, and then, so just kind of memorize this picture. I would review it like right before the test, because you'll always be asked these questions, and then we'll go through all the details. All right, so Men1, it's pretty rare, but interestingly, young patients with hyperpara, it's like 10% of them have Men1. So, so that's where you should be thinking about testing. We'll talk a little bit about genetic testing, but if you have a 25-year-old with hyperpara, that's kind of weird, right? So think about Men1. Clinical diagnosis requires 2 or more of these syndromes. So the most common, as we talked about, I think, is parathyroid for Men1. So what do they get? Let's go to Connor. So what do they specifically get in their parathyroids? Yeah, so usually it's 4 gland, right? So what that affects really is the recurrence rate if you don't do a 4 gland excision, which can be very, very high in Men1. All right, and then Jamie, now's the time. What pancreas tumors do they get? Yeah, okay. What's the second most common? Yeah. All right, so gastronoma is going to be common. And gastronomas in general are pretty rare. So anytime you have a gastronoma, you should at least think about a genetic syndrome. And then insulinomas are the most common non-syndromic or non-familial peanuts, but are fairly rare. And then depending on what you read, non-functional may actually be more common than insulinoma. Not super important, but just know that gastronoma is the most common. And again, my little trick for remembering that, what does high calcium do to stomach acid? It makes the secretion go up, right? So if you fix their hypercalcemia, it'll actually fix their ulcer. Well, it'll help their ulcer disease. But if you can remember that those 2 things are connected, then you'll remember that it's gastronoma. Sorry, I skipped ahead. Pituitary adenomas. So prolactinoma is going to be the one that you're generally tested on. The other ones are growth hormone and ACTH releasing. And then what's the other kind of weird tumors that you sometimes get with Men1? This is like, if you want to get a 99 on the abscite kind of a thing. Yeah. Where typically? Yeah. So upper, you know, so carcinoids can happen anywhere. And these are like very, very high aerodigestive tract, right? So they're going to be, think high, so lung and thymic carcinoids. And then other things that you can get with Men1. So that's what Men2. Yeah, that's 2A. There's one that like is an endocrine tumor that's pretty rare, but can happen with Men1. No. So the carcinoids are usually high, right? Thymic or lung. So you can get other adrenal tumors like ACCs can happen with Men1. And then there's kind of like other random things like lipomas and things. But, you know, potentially you might see an ACC as like listed in the family history for Men1. And that should trigger you a little bit. All right, so who would you genetic test for a Men1 syndrome? Anybody with hyperpara? Who with hyperpara would you test? Yeah, so familial hyperparathyroidism, you might think about it, particularly if they had like a high recurrence rate in their family, something like that. And then another one I mentioned, yeah, 50-40, depending on who you read. All right. Oops, I skipped one. What are you testing for? Yeah, it's pretty easy, right? The MEN1 gene, and then what does it code for? What's the protein? Yeah, so if you take MEN1 but make it a Roman numeral 1 and add an N, menin, that's what it's, what the protein that it codes for. So these are like just simple things to memorize for the test. So this is just one society's recommendation for testing. So familial, we talked about parathyroid hyperplasia under the age of 40, 50, I think is a reasonable number too. But and then if you have recurrence, it's just odd to have recurrence. It happens, but it's not super common. And if you have multi-gland hyperplasia, you should think about genetic syndromes. And then they're basically saying any gastronoma, because gastronomas are fairly rare, and I think our threshold to do genetic testing has gone down, has gotten cheaper. So now we do it pretty easily on a lot of endocrine things. And then any bronchial or thymic net, because again, they're so unusual. And then a relative with a known mutation. That one seems kind of obvious. Questions about any of that? Dr. Clifton.
Do you test kids when you have two non-functional peanuts? Would you test them?
I probably wouldn't, but these, I don't know. I mean, these are consider, right? So I don't think these are hard and fast. But no, I mean, I think that multifocal peanuts are common enough that I wouldn't be like, oh my God, it's men's syndrome. But if they had hypercalcemia too, then I would, yeah.
I've had a couple of assessments, all negative. I mean, one time like 15,
Yeah, I think in that case I would. Like 2, I probably wouldn't, but 15, And again, I think our threshold is so low, particularly in our system where I don't know. If they had to pay cash for it, maybe you wouldn't. But all right. Oops. Okay, workup. How are we going to work these patients up? So a patient presents with hypercalcemia. What are you going to do for workup? Test. Back to you. Okay. What are you ruling out with the urinary calcium? Yeah, familial hypocalciuric hypercalcemia. So yeah, that's another thing that you should always, anytime you think hyperpara, just rule out FHH every time. And then how are you going to localize? Okay, so neck ultrasound for sure. What else might you get? Bobby? Yep. So it's a SPECT CT sestamibi. And what do you expect to find in MEN1 tests on all that localization? Yeah, probably more like non-localization, right? So if all the glands take it up, it's generally just non-localizing, right? So you should think of the sestamibi as like telling you one gland versus anything else. So it's not usual to find where like you have a ton of retained uptake late in all 4 glands. It could happen, but more likely you're just going to get non-localization. And then vitamin D we didn't talk about. So you should always get a vitamin D when you're working these patients up, because what would happen if their vitamin D is low? Typically you should not have high calcium, so you probably still have hyperparathyroidism, but it can make the post-op picture very confusing. So I always try to normalize their vitamin D before you go to the operating room. And then ideally you have something of a normal vitamin D level when you're checking all these tests. But you shouldn't have high calcium if you have low vitamin D. You could have a high PTH, right? So you could have low calcium, high PTH, and low vitamin D, and that would be appropriate secondary hyperparathyroidism, which you would not operate on. But that is part of the workup. All right. So if they have a known Men syndrome and don't have hyperparathyroidism, you should check these labs annually, basically, just to try to catch it early. All right. And then for the pancreas, how do we look for tumors? Bobby, what are you going to do for a patient with known Men1 syndrome who doesn't have a known pancreas tumor? What do you want to look for it?
Let's check the panel. The secret test that's not having
every year or what?
Initially to screen them for.
Yeah, so I mean, you could look for non-functional, right? So that's one thing. There's also other, so there's like pancreatic polypeptide that picks up non-functional. So there are non-functionals that will release hormones, but they're not hormones that cause symptoms, if that makes sense. So pancreatic polypeptide is probably the most common one that you run across, where technically it is functional, it's producing this hormone, but those don't cause a syndrome, so we call them non-functional, which is a little bit confusing. But yeah, I think checking a baseline gastrin level. Carson, what drugs mess with gastrin levels that are commonly taken in America? Yeah, so you just be careful the patient's not on a PPI. So they have to be off their PPI to check a gastrin level. So if you get a gastrin level of 400 and the patient's on a PPI, I don't think they have a gastronoma. But yeah, you can check functional labs. The recommendation is to get imaging every 1 to 3 years, and that's kind of a broad range. But I would check labs annually, and then every so often get imaging. And then whether or not to go right to dotatate, I think is hard to say because it's really expensive. And if you have a teeny tiny thing that you see on dotatate but can't see otherwise, should you go after it? Probably not. Most things can be seen on a good CT scan too, or an MRI, right? So if you're going to get a CT every year for the next 40 years, it's not great. So MRI is pretty good at picking up these pancreatic lesions too. So, and then how do you screen for pituitary lesion in Men1 syndrome? Anybody? Beth? Well, how would you screen? Yeah, so prolactin level, and then checking a growth hormone. I don't know. They have a giant head, maybe check a growth hormone level, things like that. Yeah, I mean, I think that these are like not super important, but you can check growth factors every few years, and then like you said, an MRI every few years. And so one subtlety here, if you have a prolactinoma, what's that going to look like on MRI, Beth?
Taking an educated guess, I would, that's obviously a compressed space, but I would presume you would find some sort of
tumor. Excellent. So that
size greater than the normal.
Yeah, so it's a trick question. You actually probably won't, right? So typically these are microadenomas, and so they'll be very small. So you could see a tumor on MRI, but if your chemical workup is positive, but your imaging is negative, that would not be particularly surprising because they can have multiple microadenomas. And so then it's, can you control it with medicine for some time? What medicine would you give for prolactinoma? Like what? Yeah, bromocriptine is gonna be on the test. So they like to ask that. But if you could control it temporarily with medicine, you would probably do that and then operate when it got to the point where the medicine was failing. But don't be, shocked if the imaging is negative, is kind of the bottom line. And then, the recommendations say to consider a chest CT every few years for a bronchial carcinoid or thymic carcinoid. All right. And then how are we going to treat it? This is probably the more interesting part. So how are we going to treat our parathyroid disease? Let's go Connor. I think that's like a 2-level question.
3.5.
Okay, so I want you to describe 2 options and tell me why you pick one. Because what's the right answer here? One of the chiefs, is there a right answer?
I think we discussed the other week that potentially this presents.
Okay, I would say that there's not necessarily a right answer. So you have to understand both sides of the argument, I would say. So you said 3.5 gland, he said 4. Why are you choosing a 3.5 gland?
I was at 3.5 forward.
Okay. Okay. What's the downside of the 4 gland with auto transplant? Okay. How often does that happen? It's less than that. I mean, I think the published literature would say around 10%. I think on my PowerPoint, I have 6%, which seems like a very precise number, but it's probably higher than that. Like I would guess 10% or so. So what can you do if you're worried about that and you work in the DoD and nobody cares about money?
You could replant one person instead of a bunch of the drugs.
So there's a more expensive option that's better because it's not going to uptake right away, right? You're not going to get PTH levels. It probably takes months to uptake. Yeah, you can cryopreserve. So you can take a gland, cut it in half, and put half of it into their arm, and put the other half into a freezer somewhere in Austin, I think. And it's very expensive, but you can do that. And then then you have another shot, right? So you could save all all of the glands. Yes.
I mean, that may not be the most expensive, but you only need cryopreserve for like a few months. Because then the spores,
Yeah, it should
and then
uptake.
you can have them throw it away.
Sure.
But like the consequence of leaving someone aparathyroid long term may be more.
Yeah. So that's the downside to the 4. And what's the downside to the 3.5? Yeah. What's the chance in a Men1 syndrome that they recur? Huh? It's high. It's like 50%. So, and again, that's over a long period of time. So I would say actually probably over the lifetime, if you do a 3.5, the majority of them are going to recur. So that's why I think most people would choose 4 and that's what I would put on the test for a Men1 syndrome. I would put 4 gland with auto transplant because the recurrence rate is so high. All right. Always do a thymectomy because 1, the gland could be hiding there, and then 2, and then 1, maybe they have a carcinoid that you could pluck out at the same time. But always do a thymectomy, and then I think we talked about everything else. All right, pancreas, Meg, how do we treat? Are you still? You're gone.
I'm still here. Do you want me to? Do you want
Picture
to
one.
see me again?
Yeah, I don't care.
Do you
But
like my Christmas tree?
so, what are you going to do for the pancreas tumors?
You're going to resect them.
Yeah. So let's say the patient has an elevated gastrin level. It looks like they have a gastronoma, but the imaging is negative. So CT is negative, MRI is negative. Dotatate is hard to interpret because the uncinate has all this false positive in it.
I don't know.
You have no idea what else you could do?
Oh, do you do the like venous sampling
Okay, so you could do that. Where do you think the tumor is at?
in the Gastroma Triangle?
Is where?
The bounds are like where the common bile duct and the cystic duct meet, where the second and third portions of the duodenum, and where the head, the neck and body of the pancreas meet.
Okay, good. And where in that triangle are most gastronomas? This is actually a point that I think is confusing.
In the head of the pancreas.
No, so they're actually in the wall of the duodenum more commonly.
Oh.
I mean, not much more commonly, but slightly more than half. So how would you evaluate the wall of the duodenum? So maybe, dotatate lights up in the bowel. It's really confusing to interpret. So, it may not be great for duodenal tumors. So let's say you suspect that the tumor is in the wall of the duodenum. What would you do about that in the operating room?
Like just feel for it.
Yeah. How do you feel for it?
You would have to make an incision on the duodenum.
Right. Yeah, so this is a well-described maneuver where you make a incision on the lateral portion of the second portion of the duodenum across from the ampulla, basically, and then you put your finger in and run it along the medial wall of the duodenum and feel the tumor, and then you could potentially enucleate it. So, beyond the term, we say we would resect these tumors. It gets very complicated, right? So like there's lots of things that go into how you resect them and do you enucleate them, all these things. But in general, just resect. Okay. And then again, the pituitary, we kind of already talked about, no bromocriptine. And then if medical management fails, resect. And then the thymic and bronchioles, those are pretty easy, just cut them out. You can use medical therapy if you can. All right. We've kind of talked about a lot of this, but all right, yeah. So most common is going to be gastronoma, right? The syndrome associated with that is Zollinger-Ellison, which is recurrent ulcer disease. And then again, you're going to test for that with a resting gastrin level, but they have to be off their PPI. You can measure basal acid output. I can't say that I've ever done that before. But if you have equivocal findings or if they're on a PPI, you can do a secretin stim test. Franklin, what should happen when you give them secretin? Yeah, and what happens instead? Yeah. So if it goes up, if gastrin goes up with secretin, you have a gastronoma. And again, a third of randomly presenting gastronomas will have Men1 syndrome. So that's why you test when you have a gastronoma. All right. And then second most common is what? Pancreatic tumor, Franklin? Yeah. And how would you test for that? Or what's the syndrome associated with that? I guess is a better question. Yeah. What's that? So it's not really a triad. The easiest way to remember is it's not really a triad. Yeah, so you have symptoms of hypoglycemia, and what's the third thing? It gets better, right? So like, that's really just one thing, but they call it a triad. So that's Whipple's triad. And then the standard test is a 72-hour fast. So you will see patients like post-bariatric who have this hypoglycemia that's very symptomatic, and they're worried about an insulinoma. But really the only way to figure that out is to admit them for 72 hours and fast them and test them. So it's kind of a painful thing to test for. All right. And then other things, are the other pancreatic neuroendocrine tumors. So since we have time, I'm going to go through all the pancreatic neuroendocrine tumors in a second. And then general rules, when do you enucleate versus do a formal resection for pancreatic neuroendocrine tumors? Let's go McGovern. Okay. Yeah, I think that plays into your decision for sure. Yeah, so like gastronomas are much more likely to be malignant. What does that mean? Yeah, to spread somewhere. The flip side of that is that you have to be very, very sure that you don't have metastatic disease before you do like a Whipple, right? So that's the hard thing in a gastronoma is that, again, they're in the head. You usually have to make a decision about doing a Whipple or not. And then you're, with the propensity for metastatic disease, like you do a Whipple and then they have a lesion in the liver, then you feel stupid. I think dotatate has helped with that because it's much more sensitive at picking up these small lesions in the liver, but there's no way you're going to know for sure, but you just kind of have to be careful about that and make sure you've done a very thorough evaluation of the liver before you go do a Whipple. But yeah, so less than 2 centimeters. The reason why is that a distinction? Yeah, so there's retrospective data that says over 2 centimeters, you're more likely to have lymph node mets. It's based on a study from Memorial, actually, and it's kind of like this scatter plot of all the ones they cut out, and they kind of like draw this box and say like, right here seems to be the cutoff, right? So it's not hard science. And so if it's 1.9, then the chance is probably pretty good. If it's 2.1, So you have to kind of take all that with a grain of salt, but we do use that number 2 centimeters. I forgot where I was going with that, but so 2 centimeters, so less than 2 centimeters, how do you make a decision between a formal resection and a nucleation? Okay, I think that's fair. I mean, if you can do like a far distal versus a Whipple, that's going to change your decision. And then what's Phil whispering into your ear? Yeah, relationship to the duct, right? So the last thing you want to do is enucleate and leave a side hole in the main pancreatic duct. And then you've caused more of a leak than you would with a formal resection, right? So the reason we don't like doing Whipples in a neuroendocrine tumor, what is a pancreas going to look like? It's going to be soft and the duct is going to be tiny, right? So you're going to be sewing to crepe paper with a 1 millimeter duct that you can't find. And so these are the highest risk Whipples that we do, right? Neuroendocrine, if your practice is only neuroendocrine tumors, your expected leak rate is like 50%. So it's a different world than pancreas cancer, where the pancreas is hard and the duct is big. So it's just, you have to kind of factor all that into your decision making. But worse than doing that, or maybe just as bad, is you enucleate it and you just leave a hole in the duct and it's just leaking out into the peritoneum. And you've made no effort to reconstruct, and you haven't done a formal resection. So if you're going to take on that risk, just do a formal resection. And in the tail, again, my threshold to resect would be even lower because you know, if you can get a stapler across a soft pancreas with a tiny duct, your leak rate should be 20% or less, and those leaks are easier to manage. It's not that big of a deal. One distinction between a Whipple leak and a distal leak: if you have a really bad Whipple leak, what do you leak out of the hole, out of that hole? Any of the chiefs? Pancreas juice and bile, right? So leaking bile changes everything, right? So a pancreatic leak will always heal with time, but a bile leak, it's, you know, you're leaking soap, and the body can't heal in the setting of soap, essentially. So bile leaks are much, much harder to heal. I mean, they do, but if you have a really high output bile leak, it just is a nightmare and it doesn't heal well. So again, how does a bile leak if you have a pancreatic leak? Why do you leak bile? Is the hepatic OJ leaking? Huh? This is way off topic, but interesting anyway. Anybody? Yeah, I mean, nobody really knows is the reality, but the thought is probably that the hepatic OJ still heals, but you just reflux bile. I mean, it's like, you know, for those of you that have seen a Whipple, the two anastomoses are like this far apart. So you can imagine bile could reflux back through the bowel and then out your PJ. And so now you're leaking bile and pancreas juice out your PJ, and it'll never heal. If that was going on for like a month and you were desperate to fix it, how would you fix that problem? Chiefs, anybody? We are way off topic, but yeah, PTC. So I think that's the move, is you just got to get that bile drained out somewhere. So you do a PTC and then watch for dehydration, basically, right? So if you're draining a liter of bile a day, they might get dehydrated, electrolytes might get off. So a lot of times you have to put them on TPN just to keep up with the fluid, or you can do like a NJ tube and refeed the bile. Yeah, there's all kinds of ways. Way off topic. Men syndrome is very boring. So yes, I did it with that duodenal leak I had like a year ago.
No, I'm not saying I haven't read bile. I've never seen a Whipple fail that way.
I have.
One time I had a Whipple that had a high output bile leak. It turns out that I output the brain into the figured that out.
Yeah. No, I mean, I saw, I don't know, a few in fellowship when it was a bad bile leak.
When the pancreas, I mean, it always looks like they're separated, but like, you know, it's usually not that.
But I think these are the patients where it'll be that bad.
Yeah.
Like, you know, I mean, there's the guy at Anderson, Mike Kim, who does a lot of high risk Whipples. I think I saw maybe 3 or 4 like that during my 2 years there. So, I mean, if your practice is neuroendocrine tumors, it happens for sure. Okay, that was very off topic. All right, I think that's it for that. Any questions about what we talked about so far?
Sorry, that last point is still dependent on the fight. Like you
It's right. Very controversial. I personally, I wouldn't let tumor type affect me that much. Yeah, because I mean, there's 2 sides to that argument, right? Like if they're already metastatic, then what are you doing, right? And so yeah, that's another way off topic but interesting point.
More on topic than the bile.
Fair enough.
What symptoms would a non-functioning tumor have? Yeah, obstruction of pancreatic duct. We can go through there with IRMS. What about function? So Gastronoma with. So the Gastronoma is harder because the mattress of stage medication. How do you manage? Medication for PBIs. Yeah, treatment. One in one patient. 2 IV and that result, and the symptoms were really well controlled. And so like, especially in operating that in particular, some of the most symptoms of
Mhm.
pills. We have more pills before 1970. We were here. We got enough.
Yep.
Meg, are you muted?
That's not me.
Oh. Yeah, we could talk about it at the end. That's fine. Yeah. So just for the people that aren't here, Dr. Krell was talking about
you.
the threshold to resect metastatic disease, that a lot of this can be managed with medical management. And so then in that case, you don't operate, and especially with gastrinomas. And then there is literature about like, you know, if you can get 80% out, you should do it. If you can get 90% out, even though you're leaving disease behind, you should do it. It's like a debulking to help their symptoms. It's all controversial. And it's based on retrospective data of patients who got resection and did better, but those are obviously highly selected. So it's all controversial. All right. I feel like we've talked about most of this, but I just want to make sure we talk about everything. So Gastroma Triangle, we talked about 70% of these are going to be in the duodenum, not in the pancreas. Okay. So I think that's one thing that most people don't know. 30% associated with Men1. Again, 90% malignant is what we say. And a third are going to present with metastatic disease. If they have metastatic disease, you know, hard to say doing a Whipple is going to help them. But if you could potentially enucleate everything, there are people who argue for operating in that case. But I think to Dr. Krell's point, you know, give them a high dose PPI, give them somatostatin, and they generally do okay. Okay. And then we talked about how to test for it and then how to treat it. All right. Question about gastronoma? Okay. Insulinomas. So most common in non-familial, right? Insulinoma is most common in sporadic, second most common in Men1. These are found throughout the pancreas. Tommy Brown's little picture, right? The eye goes all the way across the pancreas. It's good. I mean, it's great. Yeah. And this is where, so somebody, I think, Meg, you were talking about selective venous sampling. That's really more applicable with insulinoma than gastronoma, because again, gastrinomas are almost all going to be in that triangle, but insulinomas can be anywhere. So it could be tested, very rare. I've never seen it used, but you can do selective injection of calcium, and then that will cause the insulin to go up. And so then you do venous sampling and try to figure out which third of the pancreas the insulin is coming from. Again, we talked about 72-hour fast. You got to admit the patient to diagnose these. I think that's it. Question about insulinoma? No, I mean, there's some data that some of that is probably old, because there is this weird subtlety to insulinomas that it cannot be seen on a somatostatin or a somatoscan, right? So the old SPECT imaging didn't pick up the somatostatin receptor. There are 4 types of somatostatin receptors. I think it's 2 that didn't get picked up by a somatoscan. So the old imaging, the SPECT imaging, did not pick up insulinomas. And so they were harder to find. Unless you saw them on CT or MRI, you couldn't find them. The dotatate has changed that. So dotatates do pick up insulinomas. So that's probably old, but that probably is still the answer on the ABSITE, is that if you can't see it on other imaging, do an EUS. And what you're talking about just in a GI EUS through the stomach wall. But now in 2021, I would say probably that dotatate is the most sensitive way to find it. So that's probably old information. But that is a weird subtlety that I think has been tested before, is that you cannot see insulinomas on a SPECT imaging somatoscan. So not really relevant anymore now that we have dotatate. But yeah, Octreoscan is what the word I'm looking for. Sorry, not a, yeah. That's why I couldn't say it, because it's not actually a word. I was making somatoscan is totally made up. Octreoscan, yes. All right, and then non-functional. So why are non-functional tumors going to be bigger than functional tumors? Yeah, yeah. So a gastronoma that gets to 5 centimeters, you would think you're going to have symptoms by then, right? So it seems very unlikely for a gastronoma to ever get that big, but non-functionals will get that big. All right. Blah, blah, blah. So chromogranin A, do we use that very often anymore? What do we use now? Yeah, even that's not very good. Yeah, so we have this new pancreatic polypeptide, and then there's pancreastatin is the newest one. So keep an eye out for that. That's sort of we're like all messing around with it and trying it. But the new NANETS guidelines, they basically don't give a recommendation anymore, but they don't recommend to check chromogranins anymore. So they're sort of nebulous, but they say, you know, that pancreastatin is probably more sensitive. And so not every place has it, and there's not a ton of data because it hasn't been around that long, but anyway, that's changing. All right, glucagonoma. We didn't talk about this one yet, so we should just run through this. Where do glucagonomas happen? Justin? Tail. What symptoms do they present with? Yeah, so they get, so the rash is what and why does it happen? I think this is, I always like this. I don't know why. I think it's really interesting. I wasn't asking you. No, I'm just kidding. Who said that? I didn't even hear. Phil? Oh, Phil, you be quiet. Why does it happen? Nobody heard that. He mumbled. See? Perfect. Anybody besides Phil or Alex? No. All right, Phil, go ahead. So I think this is super interesting. Yeah, why does that happen? Huh? Yeah, why do you get amino acid deficiency? Oh, so you just memorized the book. You don't actually understand it. Beth is horrified by that comment. Does anybody understand why glucagon would cause an amino acid deficiency? What does glucagon do?
I was gonna say this is wrong, but a niacin deficiency.
What does glucagon do? Oh boy, we got to go back to med school here. All right, give me a med student. What does glucagon do? Yeah, gluconeogenesis, right? What is a way to make new glucose in your body? Break down amino acids, right? So if you have a buttload of glucagon, you're turning all your amino acids into sugar, and then you don't have any amino acids left. So now you have essential amino acid deficiency, which causes a rash. And that's why you get a rash with glucagonoma. So I think that's very interesting. I don't know why, but I like it. I think that's a good example of like, if you understand the pathophysiology, you'll always remember it, whereas only Phil can memorize the book and, you know, and not actually understand what's going on. But anyway, so you get this rash. All right. So most patients are going to get this, right? And how do you fix the rash? How do you treat the rash? If you just want to treat the rash and nothing else, what would you do? Give amino acids, right? And you can fix the rash. All right.
One other thing to get along with is
Yeah. I think I covered up one of the D's, but I think that's the fourth D. So yeah, so dermatitis, diabetes, depression, or dementia. I mean, it's some mental status change, and then DVT, and then you have a sky-high glucagon. That's the diagnosis. All right. I meant for those pictures to go away, but they didn't. All right. All right. Questions about glucagonoma? You'll never forget again why they get a rash, right? And at some point you'll remember what glucagon does. That was embarrassing. All right. I don't know what. Oh, I'm going the wrong way. That's the problem. All right. What does VIPoma cause? Okay. Watery diarrhea, achlorhydria, hypokalemia. Why does that happen? I have no idea. No, it's just you just lose it all in the diarrhea, right? So it's basically diarrhea and the consequences of diarrhea. All right, watery diarrhea, hypokalemia, achlorhydria, VIP levels will be sky high. I don't know what a normal VIP level is, but 500 must be a lot. All right, and then they happen they happen all over the pancreas. I can't remember if VIP is one of the letters in Tommy's thing. The I is insulin and VIP?
Yeah, it's the body.
Oh, it's like got it. Got it. Got it. All right. Sounds good. All right. And then there's these other really rare ones. I mean, somatostatinoma does come up, right? So what do they get characteristically? Gallstones. Yeah. So if you can remember gallstones, you'll probably be good for somatostatinoma. And why do they get gallstones? Yeah, it's just stasis, right? Somatostatin kind of slows the GI tract down, so they get biliary stasis, they get gallstones. All right, that's it for Men1. Questions? All right, Men2. What's the common thread in all Men2s that everybody gets pretty much? Medullary thyroid cancer, right? So you can also think of it as a familial medullary thyroid cancer syndrome. And then what else do they get? EOs, okay. And then what's the genetic abnormality? RET proto-oncogene, right? So they're all going to have RET proto-oncogene. And any familial medullary thyroid cancer will also have the RET proto-oncogene. All right, so some lady comes in with a thyroid tumor, and the FNA shows a medullary. Let's say you're on your oral boards, Kyle. What are you going to get next? This is your oral board scenario.
You get
What are you going to do next? Go to the operating room?
no, you test for a video.
Yeah. So what are you going to get?
Urinary.
Just imagine, well, now you're on, I was going to say, just imagine you're in a hotel room, but now you're going to be on Zoom, but yeah, so plasma metanephrines, right? Okay, so that's just like one of these things. Anytime you see a medullary thyroid cancer, you have to rule out pheo. You cannot take a medullary thyroid cancer to the operating room. You will kill the patient. Always, always, always rule out pheo first, okay? All right, so 2A specifically, again, we already talked about everybody's going to get MTC, and then half are going to get pheos, and then what's the other thing that they get? Yeah, hyperpara. And then what are the other weird things? You said Hirschsprung's, and then there's something that I don't even know what it is. Yes, exactly. That's good memorization. All right, so yeah, they can get skin manifestations. All right, so workup. So medullary, what tumor markers, Beth, for medullary?
I would get calcitonin.
And
I can also get CA.
yeah, so yeah, the weird thing about, the good thing about calcitonin is it's like a perfect tumor marker, right? So it should be highly sensitive, not necessarily specific, but it should be very good to track. Like if you take all their medullary thyroid cancer out, it should normalize, and then it should go up when they come back. So you want to get a baseline before you take them to the operating room. How do we work up a pheo? Kyle, let's go back to you. So talk to me about what metanephrines you're going to get and why.
I think I said urine earlier, but plasma.
Okay.
And then
Why would you get plasma?
I think it's more sensitive for.
Yeah,
You
and because people hate peeing in a jug for a day.
24 hours.
So what happens if it's high? What if the patient had a stressful day and it's a little bit high?
They need to go to urinary.
Yeah, and why is that?
It's more specific.
Yeah, it just averages out the like daily ebbs and flows of different things, right? So that in general, plasma for screening, urinary for confirmation is kind of a good rule to remember. Just because, you know, hormones go like this as your day goes, and collecting over 24 hours, you get like the area under the curve. It should sort of average everything out, kind of the way to think of it. Okay, so let's say their metanephrines are up. What are you going to do next?
CT.
Okay.
Look for if they have any obvious tumors, adrenal tumors on there.
Okay, what if CT is negative? What else can you do?
We get MRI.
Okay, MRI is negative. This is new, so it's probably not like in the AppSite book or anything. Anybody else? DOTA, yeah. So dotatate is really good for pheos too. So what was the old scan called? MIBG was like that's probably what the Pfizer book says still, but nobody does that anymore. And again, a lot of this boils down to SPECT imaging versus PET imaging. So dotatate is PET, and it's just better. So Octreoscan was SPECT imaging, MIBG is SPECT imaging, dotatate is PET, so you just get finer detail and it's more sensitive and specific. So, so nowadays we use dotatate if we're not sure about a FIO. And then what, I'm not sure how to ask this question. Yeah.
Wanna
Okay.
explain the difference between
PET is better.
Yeah, well, so PET is like SPECT is like a X-ray, PET is like a CT.
But you can get a SPECT CT, right? But
So that's different. That's what you combine it with. Yeah, we always do get a SPECT CT. You couldn't get a. Yeah.
But the resolution on CT,
yeah.
that allows the, how we try to detect it from the result and you get a higher level. So you can merge into the diagnostic plan.
So Meg, what they said is that PET is better.
Yeah, but it's interesting. There's like-
And sorry, PET
I
is
didn't know
better.
this until like, I don't know, last year, but there was like a whole host of, I think part of this is, there's a lot of things that are doing, but one of the things is dotatate, like people all of a sudden said like, oh my gosh, like, why are we just running glucose? There's a whole ton of agents that are being developed right now. And so I think we can see a lot more of this. And the other is more of its tied with this so-called theranostic approach, where it's like, the imaging is both diagnostic but also therapeutic, like so that you get a dotatate scan and it predicts your response to treatment.
Yeah, so the DOTA molecule is like a chelator, and then you can put anything you want on the other side of it. So you can put something that lights up on the scan, or you can put a radioactive substance, right? So what is it called when you do that for peanuts, Lexi? What's the radioactive? Yeah, Lutathera, which is just a dotatate molecule, DOTA molecule with lutetium, some number that makes it scary. And you just, whatever picked up the receptor, whatever tagged on the dotatate will now be treated by that radiation. So you can do that. You know, there's a whole bunch of people developing a whole bunch of things.
Yeah, a lot of them are antibody based. So they get an antibody drug conjugate or antibody radiopharmaceutical, and they're all being
Or I did that with NIPD2, they would do one of those NIPD protein.
Yeah. All right. So chest CT for familial, why is that in there? Why would you look harder for metastatic disease for familial FIO? What percent of FIOs are metastatic? 10%, right? 10%, rule of 10s, rule of 10s. Yeah, probably less than 10. But what about for familial? So does the rule of 10s apply to familial FIOs? Hard pass, hard no. Yes, other than 10% are familial, yes. So for a sporadic, think rule of 10s. For a known familial FIO, all those rules go out the window, right? So you have to think more about metastatic. You have to think particularly about bilateral disease. So bilateral disease is exceedingly common in familial, and often they'll recur on the other side. So, all right, and then parathyroid we've talked about. All right, how do you treat medullary thyroid cancer? Let's say a 1 centimeter medullary thyroid cancer. Yeah, total plus central neck, total plus central neck, total plus central neck. That should be your answer for medullary. The bottom line is it's just more aggressive than a well-differentiated thyroid cancer, so you should just be more aggressive surgically. And then if you have any suspicion for lateral disease, biopsy it. And then let's say there's a lateral node that's positive, what would you do? Modified radical neck resection, right? So dissection. So you're just gonna be more aggressive is kind of the bottom line. And then for men too, you know, this is where that hyperpara thing gets really complicated because their recurrence rate is not as high as men 1, but it's still like, 10, 15%. And so I don't know what the right answer is there. That's kind of center-based in your discussion with the patient. What would you rather have, recurrence or low calcium for the rest of your life? Tough to say. Okay, and then how do we treat it? So let's go into FIO. So I'm going to go kind of quick through some of this. All right, so where's the most common location for an extraadrenal FIO, Maria? Well, that's what the adrenal is, so I guess that counts. But if it's not associated with adrenal, where would it be? It's everyone's favorite eponym in the history of surgery. Jamie? Exactly right. Yes. The organ of Zuckerkandl. The organ of Zuckerkandl. Where is that? Yeah, it's at the bifurcation aorta, right? So there's that plexus of nerves that you don't want to get into when you're doing an LAR, right? That's where the organ of Zuckerkandl is. So like if they present something, I feel like the classic like vignette would be a patient with a suspected pheo and they have like a GYN exam for this for some reason, and they get pressure on their pheo and their blood pressure goes crazy. So if you just think, if it's not adrenal, it's going to be at the aortic bifurcation. All right, so rule of tens. Maria, hit me. Interns. 10%. Malignant, 10%. Familial, 10%. Bilateral, 10% extra adrenal, right? So if you have a familial pheo, all this goes out the window. So do not apply these rules to familial pheo. So if you're in Men syndrome, you should not think rule of tens, okay? All right, so now let's talk about how we're gonna treat the pheo, right? So the first thing we're gonna do is alpha blockade. What kind of alpha blockade? Non-selective alpha 1, right? Why? Wait, hold on. I just said something that didn't make any sense. Are we gonna do non-selective or alpha 1? Yeah, so we're gonna do selective alpha 1 blockade. Why is that? Franklin, I think I asked you about this last week, right?
Yeah.
What does alpha 2 do?
Alpha 2 it's an central acting, and then it's stimulated. Sympathetic drive.
Yeah, alpha 2 is a negative feedback on the rest of your sympathetic drive. So if you block alpha 2, it's a double negative, right? You're activating the sympathetic system, which is not really super helpful in these patients. So if you do a non-selective blockade, you're blocking alpha 1, but stimulating beta. And so what happens when you stimulate beta 1? Tachycardia, right? So the old rule was alpha blockade until you get reflexive tachycardia and then beta blockade. Now with long-acting alpha 1 selective blockers, it's rare that you get tachycardia. What are your endpoints for blockade? Maybe Justin or Kyle? Yep. Orthostatic hypotension and the opposite, right? So when you get a runny nose, you take phenylephrine, which is a alpha 1 stimulant, right? This is alpha 1 blockade. So what are they going to get? Runny nose. Yeah. So you want rhinorrhea. All right, let's skip ahead here. So you want rhinorrhea and orthostatic hypotension. So again, these are the different kinds. And I feel like these have been asked in the past. And I think that the old AppSite answer used to be phenoxybenzamine because it was long acting rather than short acting. But now we have long acting selective, which is Cardura or doxazosin. So that's what I would answer if it was an option. If that was not an option, the question is old, then go with phenoxybenzamine. Phentolamine is short acting. That should be used in the operating room only. Okay. Adequate blockade. We talked about orthostatic hypotension, rhinorrhea. We add a beta blocker when there's tachycardia, and then other options. So what? So right before you go to the operating room, 3 days pre-op, they're adequately alpha blocked. What do you want to do? Salt load and hydrate, right? So you tell them to eat a bunch of salty food and drink a bunch of water, or if they're unreliable, you admit them for 24 hours and put them on a saline drip, right? What if they have a pheo and you can't operate on it for whatever reason? What medical drugs, what medical options do you have? Chiefs. Yeah, I don't know about the antihelminthic, to be honest, but met-tyrosine is the one that'll be on your test. And basically, it's a false analog, right? So it's kind of like 5-FU is to making DNA. Tyrosine is the rate-limiting step in making all of your sympathetic hormones. And so you just give fake tyrosine that doesn't work, and it kind of gums up the system, and then you can't make your epinephrine and norepinephrine. That's kind of the way to think of it. So met-tyrosine is kind of the therapy that we use for pheos if they're non-operative. I think that's it. Okay. All right. So pre-op, we talked about this. Intra-op, anesthesia needs to be ready with beta blockers, alpha blockers, nitroprusside, and pressors. You want to try not to mess with the tumor, no touch technique, and then clip the vein first, right? So all those things are potentially helpful. Okay. Questions about Men 2A or PHIOs or anything that we've covered so far? All right, we have 3 minutes. Men2B, also known as Men3 in Europe. It's the same except, what's the weird stuff? Marfanoid habitus. Yeah, ganglioneuromas or mucosal neuromas. And then the other thing is that, is the medullary thyroid cancer more aggressive with 2A or 2B? 2B, right? So B is bad. Somebody told me that the other day. Seems pretty simple. So the medullary thyroid cancer is worse with Men2B than with Men2A. That translates into one actual thing, right? Which is prophylactic thyroidectomy for Men2. Which one are you going to do first, and when are you going to do it? Yeah. So 2B, 1 or 2, depending on who you read. And really it depends on the mutation. Now we get into like specific mutations, and certain RET mutations are more aggressive than others. And then Men2A, when are you going to do it? Yeah, usually 5. So yeah, basically they now say with 918 as early as possible, which I don't know what that means, but yeah, early. So within the first year of life for sure for 918. And then the lower risk ones is 5 is the number. And then Men4 syndrome, I don't know, whatever. I just mentioned it at the end here, but it's really like Men1, but with some other things, right? So like these genitourinary tumors, adrenal tumors, like we talked about how Men1 can be associated with adrenal tumors. So is that really Men4? Probably, I don't know. But anyway, just keep in mind that there is this thing Men4. And how do you know it's Men4? Yes, Alex, all over it. CDK N1B. So you may see this. I mean, I don't know. Like as we get more ridiculous about memorizing random things, you may see this out there. But they do not have a Men1 mutation. They have a CDK and CDNK1B mutation. So that is the mutation for Men4. I would be shocked if they ask you that, but it's possible. All right. So just quickly, let's summarize. Men1, what do they get? 3 P's, right? Parathyroid, pancreas, pituitary. And then for parathyroid, it's going to come first. It's going to happen in 90+% of the patients. You're going to do 3.5 versus 4, probably 4 gland for Men1. And then the risk of recurrence is around 50%. If you don't do a 4 gland, there's 6% recurrent reported, 6%, probably a little more risk of permanent hypopara. So that's kind of the math that you're doing when you're talking to the patients. Pancreatic neuroendocrine is going to be Gastronoma, secretin stim test. It's, they probably won't ask about insulinoma. They'll almost certainly give you a Zollinger-Ellison patient. I don't know why I repeated that. Resect versus a nucleate. All right, Men2, you're going to have what 2 things always for Men2? Medullary and PHIO. Medullary always, PHIO less common, but those are the consistent ones with the 2 Men2s. Always get a metanephrine, right? So if you have a thyroid mass on your oral boards, ask for a calcitonin, and then when it's high, get a metanephrine. They're trying to trap you into taking a patient to the operating room. You're going to do a total and a central neck for anything over 1 centimeter, and then prophylactic is going to be, you're going to do prophylactic for 2A at 5, 2B at 1 or less. M19T is that mutation that may come up. And then for Men2A, you add hyperpara. For Men2B, you add mucosal neuromas and morphine. All right.